It's my pleasure to introduce, there you go, our next speaker, who's a crowd favorite. It's Dr. Michael Lindsay. Dr. Michael Lindsay is known to many of us as he has been at Emory in the Grady clinics, OB clinics, since '85. He completed his undergraduate studies at Morehouse. He then went to medical school at Yale and then completed his training in OBGYN at Boston University before going to Cincinnati for a fellowship, came to Atlanta, completed a master's in public health, and in '85 was at Grady, and in '86 established the HIV clinic and was very instrumental in our state getting opt-out HIV testing for our pregnant mothers as part of our routine prenatal care. Most recently, the past decade has been his focus for maternal mortality, and he has organized and achieved both for Georgia as well as District 4 tremendous organization for maternal mortality review committees and preparation of reports. And he is a man of few words, but we love it when he comes and shares his wisdom with us. So thank you, Dr. Lindsay.
Thank you for the warm introduction. I see a lot of familiar faces in the audience. And it's good to see people in person as opposed to Zoom. What do I do to advance my slides? Okay. This morning, what I want to do is I have 4 objectives. I want to describe to you how we measure maternal mortality in the U.S., describe the role of maternal mortality review committees, and explain how maternal mortality findings can effectively guide and direct prevention efforts in Georgia. I have no disclosures. You can't pick up the lay press without seeing something about maternal mortality. This is just an example of some of the headlines that have appeared recently. But the whole point of the slide is that maternal mortality is a very important public health issue, and it's something that we see and hear about daily. What I want to do is introduction is to kind of talk about the different surveillance systems and give you a perspective as I go through more of the data through the talk. Currently, there are 3 surveillance systems that are set up in the U.S., the CDC National Center for Health Statistics, the CDC Pregnancy Mortality Surveillance System, and what I'll spend a lot of time on is the third, that is maternal mortality review committees. So let's just talk about the differences between the surveillance systems. In terms of the CDC National Center for Health Statistics, they use death certificate data, looks at death during pregnancy up to 42 days postpartum. They use ICD-10 codes. The terminology that's used is maternal death. The measure is the maternal mortality ratio, which is the number of deaths per 100,000 live births. And the purpose of this surveillance system is to compare national trends to world data. So remember, the WHO uses death up to 42 days. This surveillance system uses death up to 42 days. The next surveillance system is the CDC Pregnancy Mortality Surveillance System. And they use a different data source. They use both death certificates linked to fetal birth certificates. They go from pregnancy up to 365 days. So that's the difference. 42 days for the other surveillance system, international comparison, 365 days for the CDC system. The primary source of classification is medical epidemiologists. And the terminology that's used is a little different. It's pregnancy associated, pregnancy related. I'm sure you've all you heard that terminology. Briefly, pregnancy related would be a death that's related to the physiologic changes of pregnancy. So if someone has severe preeclampsia and dies from DIC, then that's a pregnancy related death. If a person has uterine atony and dies from postpartum hemorrhage, that's a pregnancy related death. On the other hand, the other terminology is pregnancy associated, which would be a death that occurs during that 365 days. So for an example, if someone dies from an automobile accident at 6 months postpartum, it's pregnancy-associated death. The reason why it's important for the distinction is when you're calculating the maternal mortality ratio, you only use the pregnancy-related deaths, and that's really important. So that's an important distinction. The purpose of this system is to analyze clinical factors associated with death. And then the final category is the Maternal Mortality Review Committee, which will be the focus of my discussion today, and use death certificate data linked to fetal birth certificates, but in addition it uses information from the medical record and what it can ascertain from the community. It's important. The other part is it's a multidisciplinary committee. So I'll talk about our Georgia Maternal Mortality Review Committee. I think we have 35 plus members. We have obstetricians, we have psychiatrists, we have OB anesthesiologists, we have individuals who are involved in public health. So that's really important. We use the same terminology, and the whole point of having maternal mortality review committees is to understand medical and non-medical contributors to death and to prioritize interventions that may effectively reduce maternal death. These are the trends in the pregnancy-related mortality in the U.S. This is a slide taken from the CDC, and the data is from 1987 to 2017. As I give the data, there's usually a lag time of about 5 years because it takes about 5 years to accumulate the data. So that's our most recent data. But the whole point of this slide is if you look at pregnancy-related deaths per 100,000 live births, is that the rate of pregnancy-related deaths in the U.S. are increasing. And you can see the slide over that 30-year time period. If you look at the causes of pregnancy-related death, and again, this is the most recent data, the main causes of pregnancy-related death are cardiac conditions, infections, cardiomyopathy, and hemorrhage. Those were the 4 major causes in that 3-year time window. If you look at the pregnancy-related mortality by race ethnicity from 2014 to 2017, again, it reveals a persistent health disparity. If you look at non-Hispanic blacks, they have the highest rate, 41.7, and if your reference group is non-Hispanic white, it's 13.4, so if you do the math, the disparity nationwide is about threefold. That is, the number of deaths in African American women about threefold higher than in non-Hispanic whites. It's a health disparity, however, that's been persistent for the last 75 years. And so that's really important to take that into consideration because we've had a lot of discussion of how do we decrease or reduce the health disparity. I think there are a lot of strategies that have been in effect or have been suggested. But remember, it's a persistent problem, so it's not going to be solved very quickly. That's the point. Let's talk a little bit more about maternal mortality review committees. It's not a new concept. In 1930, the New York Academy of Medicine and the Philadelphia County Medical Society established maternal mortality review committees. In '68, there were 44 committees in the U.S. Over the next few decades, maternal mortality was not as important. And in 2012, we only had 18 states that have had maternal mortality review committees. With the recent emphasis and interest in maternal mortality review, we currently have 48 states that have active maternal mortality review committees. The other thing, in just kind of from a historical perspective, that nothing is new. In 1933, the Philadelphia Academy said that childbirth deaths, that 65% of them were needless. And to interpret that in modern day terminology would mean that 65% of those deaths were potentially preventable. So it's not a new concept. Let's talk about Georgia. And before I go through the maternal mortality crisis in Georgia, I want to sort of give kudos to the GOGS, who really have played a leadership role in helping us look at maternal mortality in this state. In 2010, Amnesty International published an article called Deadly Delivery, the Maternal Healthcare Crisis in the U.S. And in that article, it said that Georgia had the worst maternal mortality ratio in the country. You can look at the numbers. It was about 23.2. Remember the 25, because that's currently about where we are, and that number has really been persistent for about the last decade. based on that article in April of 2010, key stakeholders got together to strategize to come up with ways that we could address our maternal mortality crisis in the state. The initial meeting was held in 2010, which is 12 years ago now. Time really flies. But we agreed to establish an advisory committee. We had a series of planning meetings over an 18-month time period, and the consensus was to reestablish maternal mortality review in the state. In October 2010, we got a key commitment from the Georgia Director of Maternal Child Health, because one of the things, if you're going to do maternal mortality review, is you need resources, and the Georgia Department of Maternal Health agreed to provide those resources. Key role that was played by the Georgia OBGyn Society was to administer the contract and to make sure that maternal mortality review occurred. And as an aside, over the years, the GOGS has been very supportive of all of the statewide initiatives for maternal mortality review. So in 2012, about a decade ago, we established a maternal mortality review committee, reestablished one in the state. There had been one in the 90s, but it became quiescent and was not active for about a decade. One of the key points during this time period was in 2014, there was a State Bill 273 that was signed by the governor that provided legal protections for members who were part of the committee. I've mentioned that it's a multidisciplinary committee, and the way that the committee functions, and it still functions today, is that the funds come from the state. The Georgia OBGyn Society has been the contractor, and we have, and I actually want to see a show of hands of individuals who either are former members or current members of the Georgia Maternal Mortality Review Committee. I think there are quite a few in the room. Okay, so you can see that. We have quite a few who are here. We've reviewed cases from 2012 to 2020, and I'll share that data with you as the talk continues. This is a picture of the Georgia Maternal Mortality Review Committee, one of our last in-person meetings in 2019. And the whole point of the slide is you can see it's really a large committee, but one of the advantages, we had a lot of discussions about how big the committee should be, but I think one of the advantages of having a committee so large as ours is that you have a lot of key stakeholders in the room, and when you're discussing things about recommendation and implementation, you have individuals who can drive that, and I think that that's really important. What do we learn from the review from maternal mortality committees? This is a schematic. We have a death, a case definition, and I think really the key individuals involved in this whole sequence of steps is the abstractor. For those who are not familiar with the actual review, we usually have a case summary. We go over the case summary, have a robust discussion. We determine whether the pregnancy, whether the death is pregnancy related or pregnancy associated, and then we talk about recommendations. But the key part of the whole equation is getting the clear definition of what really happened during the pregnancy. As an aside, since I've been involved in the committee, when we first started, we were doing maybe about 5 cases per session in our infancy. Currently now, and this is just what's happening in the state, we currently have been meeting about 6 to 8 times a year because we've been catching up, but typically we review about 25 deaths at a session, and we just recently had actually it was last Friday we had a review, and we reviewed 24 maternal deaths. Just to kind of give you an idea of the scope of the problem, it's sad in the sense that we're reviewing so many deaths, but in the sense that if we're going to make any progress, we need to look at every death because every death counts. When we're doing review, we look at 6 questions. Was the death pregnancy related? What was the cause of death? Was the death preventable? What factors contributed to the death? What are our recommendations and actions? And what is the anticipated impact of these actions if implemented? This is just a slide showing the actual form that we use. The form is standardized. It's something that's issued from the CDC. This is something that's really been current probably for about the last 5 years that we have a national form that everyone's using so that we can learn and compare our data nationwide. So now I'm going to go through some of the data that we've collected. So in our initial review, which was from 2012 to 2014, we had 64 maternal deaths for every 100,000 live births. We reviewed 250 deaths, and 60% of those deaths were considered to be pregnancy-related. Remember, I said the pregnancy-related deaths are the ones that you use to calculate your maternal mortality ratio, and that came out to be about 26 pregnancy-related deaths per 100,000 live births. And that number, I said 25, 26, the number has been persistent over the last decade. So pregnancy mortality ratio in the state of Georgia is about 25. 25 is really easy to remember. As a frame of reference, California has the lowest maternal mortality rate in the country, and theirs is 8. So compare 8 to 25, so we're about threefold higher than what they're seeing in California. You may ask, why is California lower than Georgia? There are lots of explanations, but one of the things, and I'm sure a lot of you are aware of the California Quality Collaborative, they've done a lot of work in quality that a lot of states have sort of lagged and have followed, but they initiated a lot of these interventions almost a decade ago. And so that's one of the things we're trying to play catch up here in Georgia and nationally in terms of preventive measures. So I'm going to go through the 6 questions and share with you what the data showed for our first 2 years of looking at the deaths. Was the deaths pregnancy related? The answer was yes, but the timing of the deaths are very important. You can see in our first 2 years, about 20% of our deaths occurred after that typical 6-week postpartum period. As I give you additional data, that percentage actually is going to go up. And this data was one of the drivers for us to emphasize the need for Medicaid coverage for our postpartum women out to a year postpartum, because a lot of them are dying outside of that traditional 6-week window. What was the cause of death? In our first look at our deaths, hemorrhage, cardiovascular disease, and infection were the leading causes. That was really important as I talk a little bit later about prevention in terms of the emphasis, while we emphasize our hemorrhage bundles throughout the state. Was the death preventable? And this is kind of a textbook definition of preventability. One or more reasonable changes to patient, family, provider, system, or community factors, the death would have potentially not occurred. And in our first iteration, we found about 50% of the deaths were preventable. As we do more and more analysis, we're finding that about 75% of our maternal deaths are preventable, and that's a role that you all can play in trying to help drive down our maternal mortality. What factors contributed to the deaths? And this is also an important slide. Patient factors and provider factors were the 2 main things, but there are other factors: system of care, community, and facility factors. What are recommendations that address the contributing factors? And as we talk about recommendations, 2 of the key themes was we need to improve our training, and we need to improve procedures related to communication and coordination between providers and patients. And this are a list of some of the suggestions for training initiatives and the list of some of the things that we can do to improve communication. What is the potential for impact of the recommendations I acted on? And this is an important slide because it tells us that really if we're going to get a giant impact, we need to address the social determinants of health. And one of the things, if you look at the pyramid, the provider part, in terms of what we can do from the provider is kind of up higher on the pyramid. So we can implement all kind of bundles, we can do all these things, but if we really want to drive down the rate of maternal mortality in the state and in the nation, we're going to have to address the social determinants of health. And I realize that that's not something that we're trained to do as providers, but it's really, really important, and it's something that has become more and more important. If a mother can't get to her prenatal appointment because she doesn't have transportation, or she can't get her blood pressure medication because she doesn't have any money, we can come up with as many bundles as we want to have. We can have our head in the sand, but we're not going to drive down the maternal mortality ratio. So that's a really important theme. The other thing I wanted to share with you, and this is something that we do in the state of Georgia and in Mississippi, is what's called a key informant interview. And I'm not going to go through a lot of details, but I sort of share the data, and I think it's really important. So what the key informant interviews concept is we have Courtney Daniels, who's a licensed social worker, and everyone who's participating on Maternal Mortality Review Committee can attest to what I'm saying. She reaches out to a family member of the decedent, and she gets detailed information about what happened. And sometimes that information obviously is not captured in the medical record. So it's really to look at a more comprehensive approach. The areas that she highlights in her discussions are barriers to care, experience of discrimination or racism, social determinants of health, and the feeling of support and stressors. Everyone's eligible to be interviewed, but I think in our typical session, maybe a third to a quarter of the decedents may have key informant interviews, and recently it actually has been higher than that, but it's really a really good supplement to the medical information that we have. The interviewer role is to guide storytelling by using the established questionnaire, establish rapport, motivational interview, identify needs, and provide appropriate resources. The whole rationale for doing the key informant interview is to honor the loved one, instill a sense of purpose in the loss, to assist with resources if they're needed, opportunity for education both from our side and from actually the decedent's family side. And that she always asks them at the end whether they have any recommendations that they want to share with the committee. So this is some of the feedback that she's received from some of the families that she's reached out to. I can't even explain the happiness I felt when I received your letter and call to finally know that even one person cared about the death means so much. I want to tell you how much I appreciate being able to have this conversation on behalf of my whole family. It's important for us to know that Georgia really does care. I'm grateful for the opportunity to share her story if it can help other women. This has been very positive. I'm glad there's someone thinking about why these women do what they do. The interview, the whole point is to try to capture the full story, and I think the key informant interview gives us details that we would never capture by just looking at the record. Oops, can I go back one? That's all right. I was going to give some examples of how the key informant interview helped us really in our deliberations. There were a couple of cases, one that we were trying to decide whether or not the case was a suicide, and by talking to the key informant, they provided intimate details that we would have never captured from the medical record, so it helped us a lot in terms of making that distinction. So again, the key informant interview has really been a helpful supplement to the medical record. So now I'm going to give you more data looking at the Maternal Mortality Review report, and this is our most recent report from 2017. Currently, there's a report that will be finished by the end of the summer that will look at data going forward. So I'm going to share with you data from 2012 to 2017. 516 maternal deaths were reviewed during that time period. A little over a third of the maternal deaths were determined to be pregnancy-related, and 75% of the pregnancy-related deaths were deemed to be preventable. Remember, I said 75%, so that's really important. So that's a role that we all can play in helping to prevent deaths. This is looking at the mortality ratio over two time periods, 2012 to 2014, which was the initial data that I presented to you, and then 2015 to 2017. The bottom line is if you look at the top number of pregnancy-related mortality ratio has been stable, and I said 25. It's been approximately 25 during that time period, and for the whole decade it's been stable. This is a comparison of the percent of pregnancy-associated deaths. So the pregnancy-associated deaths is a combination of all of the deaths, both the preventable and the associated deaths. And you can look the whole slide from the 15 to 27 time period, you can see that the number of preventable deaths have increased. This is just being shown in a graphic fashion what I just said to you, that the number of preventable deaths over the time frame have gone up. This is the key slide about the timing of death in relation to the end of pregnancy. And the point is, if you look at the 2012 to 2017, which is the one on the far left, about 50% of the deaths occur after that crucial 42-day postpartum window, which made the message loud and clear that we needed to provide coverage for women after the traditional 42-day postpartum period. Pregnancy mortality ratio by race in Georgia, again, nothing new, but during the time period, in white non-Hispanics, it was 17.9, in black non-Hispanics, 41.1. Again, if you do the math, it's a threefold increase in African-American women in the state, persistent with what's being seen nationally, and it's a health disparity that we're all aware of and that we're trying to address on a daily basis. Looking at the pregnancy mortality ratio by age in Georgia, you can see that a majority of our women are dying at 35 years or older, which is really important in terms of it makes sense. This is a group that has existing comorbidities, hypertension, diabetes, other risk factors, and that's something that was shown in the data. But don't forget the under 25 population. Almost 20% of our deaths also occur in women who are less than 25 or younger in the state. And it's a tragedy for any death, but it's a double tragedy to have a maternal mortality in someone who's less than 25. This is something that we looked at very closely, pregnancy-associated ratio by location of residence at time of death, and we looked at it stratifying both urban and rural, and you can look that there's really from the whole time frame, if you look at the different time intervals, there's no difference in the ratio whether it's urban or rural. We had a hypothesis that more deaths may occur in the rural area because of a lack of providers. We really don't have any data, at least in the state of Georgia, to show that. We actually had a study, Dr. Plattner, who's one of our MFMs at Emory, when she was I think she was a resident or a fellow. My time frame merges because I've been around so long, but anyway. She actually did an analysis where she looked at our data early and showed that there really wasn't any difference urban versus rural, but that's something that really needs to be looked at again. She looked at it in our 2012 to 2014 window. So I think that that's something important to look at because a lot of things have happened in that time period. So again, and just as an aside, there is some national data that shows that there is a difference in the maternal mortality ratio in the urban versus rural being higher in a rural setting. So again, that's something we need to look at again or examine again here in the state of Georgia. The leading causes of pregnancy-related deaths, and actually on the committee, this was a surprise to me, I'll be candid. I thought when we first started that we would have the traditional causes of maternal mortality, but we found a lot of cardiovascular, cardiomyopathy, and hemorrhage were the three leading causes. And the thing that was really surprising to me is there are a lot of young women who are obese, who have cardiomyopathy, and who have cardiac disease who are dying in the state. And again, from a prevention standpoint and making recommendations, that's something that's really important. And I know Dr. Ellis and a lot of individuals in the room, GAP-QC, are working on rolling out our cardiac bundle for the state. So as you as a provider, if they contact you to get involved, that's a very important potential prevention effort in our state because we have a lot of cardiac disease and it's killing a lot of our young mothers. So that's really important. And again, you learn something every day. I actually didn't know this. I had some preconceived notions. And as I lived, I realized a lot of my preconceived notions are biting the dust. These are the leading causes of pregnancy-associated but not related deaths. So again, we make a lot of emphasis on the related deaths, but we don't want to forget the associated deaths. We have a lot of motor vehicle deaths. Again, as a clinician, encourage your patients to wear their seatbelts. That's a really important thing, and definitely once they have a baby in the car, they really need to wear their seatbelts. We see a lot of motor vehicle deaths, drug toxicity, homicide, which is really sad, and there are a lot of homicides in our postpartum period and even during the prenatal period. So again, all of these potential areas are very important to kind of emphasize, and we shouldn't lose sight of them. This is just looking at the cardiovascular and coronary conditions specifically, since it's played such a prominent role in our deaths. There have been a lot of factors that are involved, but looking at this, we were looking at some of the common themes that potentially could be addressed to prevent some of these deaths. Some of them are related to medication, lack of prenatal care, lack of access or use of family planning, obesity. Some of them are related to the inability to transfer patients. And then one of the big system factors was, and we repetitively saw this, was a lack of insurance coverage after that postpartum period ended, and we had patients who were suffering all kinds of medical complications that in theory could have been addressed if they were seen by a provider, but they didn't have any coverage. And so the Medicaid expansion, we hope, will address that crucial issue. And then the other thing that we look at is we look at comorbidities when we do our analysis, and what this slide shows is the percent of deaths were factors, comorbidities we thought were related, and looking at the pregnancy-related, not surprising, obesity is really an important contributing factor. Mental health status and substance use is also important. So after 9 years of review, many opportunities for improvement were identified, and they fall into two major categories: education of providers, patients, and the community about common problems, and then early identifications of risk factors. So I'm going to walk you through some of the opportunities for prevention in the state. I want to give a shout out to the Georgia Perinatal Quality Collaborative, started in 2012, and I know some of the individuals in this room were instrumental in helping to get that started. The goal is to identify and implement quality initiatives to improve both maternal and neonatal outcomes. And as I mentioned, we have a series of bundles that they have been instrumental in rolling out in the state. I think we've probably completed our hemorrhage bundle or pretty close to it. But as I said, the cardiac bundle is being rolled out now, and that's a really important one. Remember, cardiovascular disease, cardiomyopathy are two of the big drivers of maternal mortality in our state. So these are some of the recommendations: medical educational opportunities, community educational opportunities, and policy recommendations. I'm going to admit, as you give talks, you kind of steal people's slides, and I do this a lot. But these are slides, and I want to attribute the person who I took the slides from, and it's Dr. Ellis. I'm looking at her in the back. These slides came from a talk that she gave, and she has been instrumental in helping to drive some of the prevention efforts in the state. So from a medical educational opportunities, partner with GAP QC to implement our AIM patient safety bundles, talk about hemorrhage and hypertension, but as I said, cardiac disease is the next one, and there are additional ones that I'm sure that they'll be rolling out over time. Consider appropriate consults for high-risk patients, and that's really important. In our analysis of a lot of cases, we sometimes question the timing or the lack of timing of consults. We have our regional perinatal centers. We need to leverage them. If you have a regional perinatal center in your area and you have a high-risk patient, just pick up the phone and give them a call and see if they can assist you. Encourage interconceptual and postpartum follow-up and care. I had a great talk by Dr. Wu about encourage depression screening during pregnancy and the postpartum period. So all of those things are very important from a medical educational opportunities. From community educational opportunities, partner with community agents to promote prenatal care and evidence-based programs such as centering pregnancy. Publicize the importance of following providers' recommendations to ensure a healthy pregnancy. Support contraception and education about LARC. And I've already mentioned, but I just want to reiterate the importance of our regional perinatal center for referral of high-risk pregnancies and coordination of patient safety initiatives. Policy recommendations support legislation to preserve women's health systems, including rural labor and delivery units. I mentioned that, and everyone knows about the closure of rural hospitals, and we need to be advocates to make sure that that population gets care in our state. Maintain and increase funding for public health department. And this was a bullet at the time that this slide was put together, and I didn't take it off, but work to extend insurance coverage into months after delivery. A lot of the individuals in this room were crucial in helping to get Medicaid coverage to a year postpartum in our patient population in the state of Georgia. And as you listen to the news in our political climate, that's really a hot political issue in terms of reproductive health. There are other states that don't have Medicaid coverage to a year postpartum. A lot of times when I'm in national forums, you're not embarrassed when you're from Georgia, but when they tell you you're last, then that's not something that's positive. But if we're saying we're doing something positive in terms of Medicaid coverage, so I give the governor kudos for that, but I don't give him a lot of kudos. So this is not a political announcement. Support implementation of the designated maternal levels of care. And then I just wanted to emphasize, this is the Georgia Senate Bill 496, which requires the medical examiner to perform autopsy. So let me back up. One of the things in terms of determining the pregnancy relatedness when we go through our review is to use the autopsy information, and it's so rich and valuable. Because sometimes we can have a really detailed discussion. This patient doesn't have a pulmonary embolus, she doesn't have an amniotic fluid embolus. We go through a lot of discussion, and then you get the autopsy findings, and it shows that the patient indeed did have a pulmonary embolus or had an amniotic fluid embolus. One of the things, though, that we found, about 50% of the cases that we were reviewing did not have autopsies. And so to make the review more informative, one of the recommendations was that we get legislation to require that all maternal deaths prompt an autopsy. And Georgia Senate Bill 496, which just passed into law this spring, actually does that. Law requires the medical examiner to perform an autopsy on all the maternal deaths for the first year after delivery, and it was passed in the spring. And so again, that's just a tool to help us in our analysis to determine whether the death was pregnancy related or pregnancy associated. I know that April has passed, but I had this in, and I think this is such an important slide, and I give these talks, and I have different slides. Sometimes I take them out, sometimes I don't, but I realize it's not April. But the whole point is we talk a lot about health disparities, and this is a prompt for me. This is a group that's really addressing health disparities in Metro Atlanta, and they actually started Black Maternal Health Week. It actually occurs every April. This is maybe the third, I think they've done it for 3 years, but they do it in April. And their whole point is to deepen the conversation about Black maternal health, amplify community-driven policy, research, and care solutions, and center the voices of Black mothers, families, and stakeholders, and to provide a national platform on maternal health and reproductive justice. And I think it's important. Remember I said that the health disparity has been persistent. That doesn't mean that it can't be decreased, but it's not going to be decreased if we don't have dialogue and try to come up with innovative solutions. And this has been a group that's been in the forefront of keeping the discussion on everyone's radar. Okay, when I got up this morning, I didn't know if 50 minutes would be enough, but 50 minutes was enough. So this is my last slide, that's why I'm saying this. Georgia maternal mortality reviews provide valuable information reducing morbidity and mortality. Statewide quality improvement initiatives can assist in reducing morbidity and mortality. So I just want to give everyone a message, and I'm involved in this a lot in terms of quality initiatives. People get frustrated when they see the crude rate does not decrease. So I've told you the rate has been the same in the state of Georgia for the last 10 years. But that doesn't mean that you shouldn't continue to work on initiatives to try to drive down the rate. Now, the rate may be a crude parameter, and you are having success at the margins, but don't get frustrated. And I deal with this every week because I'm involved in a postpartum hemorrhage quality initiative, and we meet every week, and people get frustrated because the hemorrhage rate is not decreasing. I'm saying, wow, I mean, let's keep putting in interventions, and at some point, the rate may decrease, or maybe the rate is not sensitive enough to measure or capture what you're doing. So I give that as a message, but it's also important to be cognizant that we are being measured, and Georgia still has the worst maternal mortality ratio in the country. So there's a lot of work to be done. Again, I want to thank the Georgia OBGyn Society, because over the years they've given me an opportunity to share with you what we've been doing. Again, this has been a group effort. I want to acknowledge all the members who work on the Georgia Maternal Mortality Review Committee. It's a labor of love. No one gets reimbursed. And our whole goal is to make childbirth safer for mothers in the state of Georgia. That concludes my talk, and those are my references, and I'll be willing to entertain any comments or questions.
Thank you, Dr. Lindsay. Another wonderful talk on this subject, and we'll go to Dr. Karakin.
Hi, Jeff Karakin, Atlanta, Georgia. This is really not a question, it's just a comment. I want to personally thank Michael for taking on this project of reviving the maternal mortality review committee. He has done a marvelous job. Many of you are not at our meetings. I am. I sit there all day. And he just has done a tremendous amount of work, and we really do appreciate it, Michael.
Okay. Thank you. So I always have the right to tell a little story since Jeff stood up. So I'm going to tell you how I got involved in maternal mortality, and he knows I told this story a lot of times. I was at a District 4 meeting, and we were going to a maternal mortality committee, and at that point, we didn't have a lot of things organized in Georgia. And I was just going to the meeting to kind of see what was going on. And as I was walking with Dr. Karakin, he appointed me as the chair of Georgia Maternal Mortality Review Committee. And that's a true story.
Okay, we'll go over to Dr. Perry.
Carrie Perry. I'm a generalist in Athens and serving as president this year. And he stole my thunder because that's my dual intention, but my first intention was to tell you that everyone here and everyone not here owes you a great debt of gratitude. I remember when you started this, I can remember the meeting where after you had been appointed that way, and I think you told that story then, and you did not have gray hair then. So
yes, he did.
He has left a lot of skin on the road, and a lot of time has been taken, and the fact you've stuck with it, we really, really appreciate your devotion. We're caught up. We're caught up. I mean, that for somebody like me, that when you give me a task, I want to be done with it. This has been indeed a labor. We're caught up now, and I think the thing that impresses me is the granularity of the data are so important. And in terms of next steps and how we really want to take this and the work that you've done and the information you've given to us and understanding those social determinants of health. I think the next step is going to be looking at some of these communities that we can hopefully identify as needing extra sources and resources of help. I get the importance of de-identified data, but do you ever see there being a time when we can pinpoint certain communities, certain hospitals? I'm not even going to go down the road of certain providers, but maybe places we can focus our resources to better offer that help.
I think the short answer is yes. I think we have, as an exercise, we've de-identified the data, but we have the ability to look at those things as we get further and further along in the process.
Next, Roland.
Again, thank you, Dr. Lindsay, for quite an informative presentation this morning. It's striking to me the difference in the numbers between Georgia and California. And at least when I look at the number, I'm not a statistician, but the white rate in Georgia is still significantly higher than the rate in California. So is there something, or what are the barriers to us doing exactly what California is doing in Georgia? Do you have any thoughts about that? I mean, can we list the things that's happening in California against what is happening or not happening in Georgia and try to figure out, because I'm sure everyone would like us to at least get to the California numbers.
I think the short answer is that California probably has a 10 to 12 year lead on the state of Georgia. So if you ask that question 10 or 12 years from now, the answer may be a little different. And I think a lot of states are kind of, for lack of a better term, playing catch up. And so, for example, the cardiac bundle that we're going to roll out in Georgia has already been implemented in California. Mm-hmm. The hemorrhage bundles, the hypertensive bundles, they all came from California. Dr. Ellis has her hands up, and I got to, she controls me at Grady, so whenever I see her hand up, I got to acknowledge her. So, Dr. Ellis.
I have one thing to say, but I have to also recognize. Come to the microphone.
Not to skip ahead of anyone, but I saw her hand, and I kind of have to.
And I also have to recognize Dr. Lindsay for covering for me for many clinics when I got out to do gap QC stuff, so thank you. Keep it up. Also, with respect to California, I just wanted to let you guys know that at Emory on October 5th, we're going to have as our grand round speaker Dr. Afshan Hamid, who is the MFM cardiologist that has led the cardiac bundle in California. She's giving grand rounds for us. We're going to make a link available so that any provider statewide can participate. It will be recorded and available later. So that would be a good time, Dr. Matthews, to listen in and ask questions of her for how they have made it work in California. She's been working with us in Georgia. She's been invaluable. So I think she'll have a lot to contribute. So please listen in to what she has to say.
Okay, let's go over here to this microphone next.
Hey, I'm Dr. Erin O'Brien. One of the things, I'm from Florida, but trained in Texas and worked there for 13 years. So seeing the differences in the Texas mortality program and the Florida mortality program were pretty telling to me. But one of the things that has worked for us and Dr. Sappenfield and FPQC is that the Florida legislature this year mandated that every hospital in the state of Florida that delivered patients had to be part of at least 2 safety bundles. They don't have a choice. They also have to report all of that data from every hospital for every outcome to the state. And you can see, I'll show you on my iPad right now, I can bring up every single county and know what the C-section rate is in that county per hospital, what the hemorrhage rate is per hospital. And anyone can get it. Like they call it the Sunshine Law for the Sunshine State, but that data is available to anyone. So as a plan, we use it, the hospitals use it to compare to each other, and the providers know what that data is. Every single C-section rate in the state, you can check. And, you know, there's a lot that Florida legislature's done well recently, but that is good because they have to be part of it. Everyone has to be part of that training, and it's mandated. So that might be something to consider. Because I remember telling Dr. Washington Hill that he didn't have to go all the way to Africa because Polk County actually has worse maternal mortality rates than most sub-Saharan Africa. And that's horrific.
Thank you for sharing that. That may be an idea what we need to pursue here in the state. Thank you.
And is that Teresa Bird?
No, it's. Hi, I'm Dr. Catrice Lares. I'm a hospitalist and at Northside Hospital currently, but I've also worked in Athens and other areas in Atlanta. Thank you for your work, and I think as a hospitalist, I get to see a lot of people who do not have access, and who say they don't have access, or they're trying to get Medicaid, and it is taking so long to get it. So I'm just wondering, with the review committee, I see that access is one of primary reasons people end up on your committee reviews. And has the committee ever had a chance to talk to Medicaid, or state Medicaid, about how can we get them coverage faster, or how can we get reimbursements faster to providers so they'll take in more patients?
The answer is we have a Medicaid representative on our committee, but in terms of, and you know this, from going from a policy discussion to actually having something happen, there are a lot of steps, but it's something that's on the radar, and we've had a lot of discussion about increasing access.
Sorry, Catrice, I didn't recognize you. We're in the spots. Sorry. Dr. DeVoe?
Yeah, Michael, you and I go back about the same amount of time. Maybe I haven't been here a little longer than you have, but one of the things that you point out here is the multifactorial nature of maternal death. You can have a leading diagnosis, but there are all these contributors to it. And the thing that occurs to me, and we've started doing something like this in our institution, is we've looked at, for example, teasing out a cardio-obstetrics system where patients with cardiac problems are identified early on in the game, and then they are basically co-managed with the cardiologist who has a specific interest in obstetrics. So that's what is one step. But I think one of the problems that is inherent in this is the prenatal care model that we all trained under, which goes back decades. And the prenatal form that we use goes back to the beginning of time, may not be the model that we need to be using anymore. And we really need to tease that model down to be much more patient-specific. Because when you look at these causes, a lot of them are not mysteries. And a lot of them are knowable causes or risk factors well in advance of whatever happens. And I would urge the committee to start actually looking at templates that we can make much more specific to the conditions that we know that patients already bring with them, so that their care is much better defined, and perhaps we have more lead time to prevent some of these outcomes than we've had in the past.
Okay. Thank you for the suggestion. We'll consider that.
I think you see her before.
Dr. Royak?
Oh, go ahead.
Tony Royak, Savannah. So we see about 25 consults a day in our office, and I would say in early 2019, probably about 80 to 90% of those patients were eligible for low-dose aspirin based upon ACOG Committee Opinion July 2018. And today, we're seeing I'd say about 50% of the patients in my office for consultation are still eligible for that treatment, and they're not receiving it. So that's a small part of what we can do every day, is to pay close attention to patients with risk factors for preeclampsia. But my question really has to do with the bite of the committee in terms of coercing some of our private physicians to engage with us from a bariatric surgery perspective and patients from a cardiac perspective. So I basically have had no interest from any of the private practitioners from a cardiology or bariatric surgery perspective to participate. And I know patients can benefit from both of those programs. So what bite does the committee have to incentivize these practitioners to work with us?
Well, we don't have any bite specifically, but I think in terms of our approach is really to our role is really to kind of track what's happening in terms of the actual deaths, to make recommendations, but in terms of the implementation, we have to rely on someone else to implement that. And in terms of, you've identified kind of a key group that needs to have additional education. I mean, we can play the role, and I don't know whether it would be helpful, but to share some of this maternal mortality review data with your colleagues, make an argument or persuasive argument that if we're going to decrease it, we need to have multidisciplinary kind of approach to prevention. And I think that that would be the start. But in terms of the committee, we don't have the clout that we can go in and, you know, tell people what to do, but we can kind of share what we're recording. And I keep emphasizing we have the worst maternal mortality in the country, so I would think that that would be an argument that you could use to at least get in the door to try to make a presentation to your colleagues.
Hi, I'm Katrina Strozier. I'm in Columbus, Georgia. It's so good to see you. I enjoyed the talk, and I know we probably all need a break, so I'll try to make this brief. But you mentioned in your slides something about education on filling out the death certificate. Oftentimes, the obstetrician may not even receive that paperwork, so that's usually done probably by the hospitalist. What barriers did you face, or what were you seeing with those death certificates? Why that was kind of it was mentioned in the slides.
There's been a lot of work from the CDC's angle in terms of, as you're right, providers usually don't fill out death certificates in most hospitals, but there's been a lot of emphasis. And one of the things I didn't actually mention this, it's not going to answer your question directly, but there's been a lot of emphasis nationwide to capture more replicated data in terms of maternal mortality, and the CDC actually has set up a group. I think there are probably about 35 states, and Georgia's one of them, where they're trying to standardize the process of reporting maternal deaths, and one of the things is that they're looking at a way to make sure that they're capturing all of the deaths accurately and training the person who's filling out the form. That didn't answer your question specifically, but that's something that's been identified as being one of the potential confounders in reporting the deaths, that the death certificate hadn't been accurately filled out, and the CDC has acknowledged that, and they're making an effort to train people to do that.
Okay, I have one more thing I'd like to just kind of point out. I know that physician burnout has become extremely significant, and when I think about, I was in a very busy hospital-based practice. I've spent the last year doing locums, traveling around. The patient population that we're dealing with is extremely sick. I remember doing 10 new OBs one week, and 8 needed to go to MFM for a reason. And when we look at our specialty, we take care of so much. We do a lot. These other specialists, you know, primary care, internal medicine, it's like once patients are pregnant, they're no longer a patient to them. How do we, you know, have those conversations, empower these other specialists to still put their hands on a pregnant patient, still help us with the care, the management, because we're just taking care of a lot more sicker patients in the state?
My short answer would be one provider at a time. I mean, when you have a patient and you need to reach out to your colleagues to help you, then, you know, you have to reach out to them. And like I said, I mean, one of the things, not that you can have a long discussion with someone, but if you have the worst maternal mortality ratio in the country, and I'm calling about a pregnant patient, you know, if you're getting a little resistance, it may help to kind of mention that we're not doing very well in the state of Georgia.
Hey, Sandra, I think you were here first. Either way, it doesn't matter. Sandra Reed, Emory University, gynecology now, and chair of District 4 ACOG. But ACOG National is looking at this topic of cross-specialty support of women's maternal health. And in the state of Georgia, we do have a primary care coalition that we could work through, and maybe that's an initiative this organization wants to look at in order to bring maternal health foremost and up front with them. The primary care community is very open. They see what's happening in our state in maternal health. And we have to start with the leadership and let it trickle down into the communities. But one of the most frustrating things is when you're in the trenches in rural Georgia taking care of a sick patient with a cardiomyopathy, a lot of the local cardiologists have no clue about maternal physiology. And God forbid you have to do a cesarean section and then they get volume overload, because it's a very different animal. And these are issues that we need to start addressing as an organization with our colleagues.
Thank you.
Hey, this is Missy Kottke again from Atlanta, Emory, and that's a perfect segue to what I wanted to bring up. Thank you. I want to echo the thanks. You know, for many years, many of you have probably heard me say, I think Georgia is like this place of best kept secrets, and our Maternal Mortality Review Committee is one of them. But the foundation that you've given and the direction that we can get from this work, I think, is super important, and I'm very excited. Thank you for talking about GAP QC, because it feels like everything's kind of moving in a very forward, positive way, and I love that. So the bundle, the cardiac bundle, Dr. Lindsay's mentioned a couple of times, is rolling out. If your hospital has not signed up, please do so. Lisa Ely is right there. She's from the Department of Public Health, our fearless leader of maternal programs at GAP QC. She has a booth. Please go visit, see if your hospital is a part of it. If not, please, please, please consider joining and being that physician lead, boots on the ground in your community, because you're the person who knows. And then to follow up Tony's question, some of the things that we're working on for GAP QC is to start to codify some of, in particular, the cardiac referral networks across the state, because we know that that's a problem. So answer the survey if we send it to you, and then hopefully we'll be able to share that. But I think this, coupled with our Medicaid extension, I love the bariatric surgery idea. We're going to put that on the list. But thank you all. Thank you.
Thank you.
Michael, I apologize for coming back, but I do have one question. When we talk about Georgia being 365 days, are all the states in the country the same, or are some states looking at different time frames for maternal death?
I actually don't know the answer to that one. I don't.
Yeah, some states do use 42 days of the traditional 6-week postpartum. California, for example, only looks 42 days.
That was one of my thoughts was California, because obviously their numbers are going to be a lot less because they're not looking at what goes on after the 6-week date.
Hey, I was just going to answer Dr. Reed's question that the Maternal Health Echo program is designed to be a hub and spoke program. Do you want to talk a little bit more about that and how our colleagues might use it to consult with from some of the outlying regions into central areas?
I'm not familiar with that program. Okay. So did you want to share?
So Project Echo is it's almost like a tumor board would be, where specialists, where you can bring a case forward to specialists and submit it and say, you know, what are the recommendations? What would you do? So there's actually on the DPPH website, maternal health page, a link to Project Echo, and as well as forms where you can submit cases. I think the ones that are up there right now are specific for hemorrhage or hypertension. But if you have a case, like Dr. Reed had mentioned, you are not in an area where you can get to a specialist and you know that there's something you're going to have to deal with, you can bring that case forward to Echo and discuss it and discuss it not just from a retrospective position, but from an active position as well.
Thank you.
Teresa Bird, and I'm here from Wellstar, but work with Dr. Kottke on GAP QC and Dr. Ellis. And I just wanted to put a plug here too, for those of you that don't know, if your hospitals are not involved with GAP QC and with the bundle, some of the other things that we're working on potentially are some patient-facing screening tools that you can use that come from the California Perinatal Quality Collaborative that help the patients realize when they have severe symptoms. So these are things potentially that we are hoping to distribute, but we're working on committees to get them out. Also things for providers to screen patients for cardiac symptoms. If you're currently not screening patients in your office for cardiac symptoms, that is something that should be done, and it has been shown to improve outcomes. Other things that we're looking to do are really trying to get some cardiologists, OB, anesthesia, MFMs on board to help us to, we have a kind of a toolkit or a kind of quick reference sheet for patients with those severe cardiac disease labeled by the WHO, like pulmonary arterial hypertension, aortic stenosis, cardiomyopathy, just to help providers if they show up on your doorstep in rural Georgia or community hospital and you don't have yet that cardiologist that's well versed in maternal physiology, things to do so that you don't kill the patient essentially, right? Like Dr. Reed was saying, you don't then just load her with fluids and realize that most of her disease is volume dependent and rate dependent. So some things we don't even know, to just put them on a beta blocker and diurese her aggressively to get the ball rolling, to buy you more time to get her there. So we're working on some of these things that then providers can use. So if you think that that's something that you'd be interested in, again, reach out to me, reach out to Dr. Kotke or Lisa to really get on board, because we do need help. We're kind of doing this by ourselves while we work our main job. I am a program director and I see patients, so it's kind of hard. So any help we can get, if you're of interest or you need these things, then you can also help recruit so we can get more people on board. Thanks.
I was told to make an announcement by Dr. Ellis that in the break, if you trained in one of the Emory affiliated programs or you worked at Grady, we're taking a picture. That's what she told me.
I'm just going to make one last closing comment. Dr. Lindsay gave a lecture for the District 4 annual meeting last year. It was one of the pre-meeting lectures. And at that lecture, the key informant piece was really covered beautifully, and Courtney actually spoke to these stories. And it's very powerful to hear the patient's family's perspective about what happens. And I think we all can learn a tremendous amount about our personal care and how we come across to patients too when you hear these stories. So I'll put a plug. That should be on video and available through the D4 meeting.